All right. Well, I think we'll go ahead and get started. And hopefully, if other folks want to join, they will hop on. Welcome. Thanks for joining. I feel like it's been a while since we've done a medical update. So I've got a lot to share. Hopefully, you can see my screen, and we will just go ahead and begin with the slides. Can everybody see the slides?
Yes, we can see him.
Okay, great. Thank you. All right. Well, the triple demic is hitting, so that's going to be the majority of my comments today. We'll talk about COVID, flu, RSV. There's actually a good amount of messaging from the CDC and the health department at the state level, which is one reason that we haven't been as active with our messaging, although we are creating a local surge advisory that will hopefully cover not just our county, but we're actually trying to bundle in some of the other neighboring counties as well as a regional advisory. Just to let you know, behind the scenes, we're doing a lot of collaboration and coordination at the level of hospitals, definitely, but also at the level of the different health departments, et cetera. It just feels like we've gone through this several times. And so here we are again at the start of another winter surge. This one has a little bit different flavor just because I don't think we had as significant of an impact of flu and RSV as we are having now. But nonetheless, a lot of the same dynamics and measures are still going to be in play. And then I'm going to end on some good news, which is a lot of good stuff is happening with the otherwise tragic epidemic of substance use disorder, which, as you all probably know by now, is one of my passions to talk about. So I'll share a lot of good news to end the day. All right, COVID updates. Well, here's where our numbers are going. If you'll remember the blueprint and the color coding, you'll know purple is bad and red is just a little better, but not much better. And really, you want to be in orange, yellow, or green. Well, it turns out that as of 11/3, we were still kind of in the orange and kind of ticking up. So we've gone from a positivity rate of 4.2 to 4.5 in the health equity, the lowest quartile of the Healthy Places Index. It's also trickling up from 2.8 to 3.1. That aligns with what we're seeing in some of our epidemiology, and I'll share that in a minute. If you look at the hospitals, the COVID numbers look kind of static. They may be a little high, but they're static. We're sort of in the 70s at the hospital level with the number of COVID patients, just a handful in the ICU, which is probably very fortunate compared to how things were last winter. And around the state, you see that the numbers are what they are, and no one's really, jumping up and down and worried about the COVID numbers right now. However, this is very telling. This is what's happening in the wastewater. So in the wastewater, this is probably one of the earliest signals that you're going to have a surge coming up. And that basically happens because the wastewater, people start to shed COVID viruses even before they get really sick, even before they spread it to the most vulnerable people who are probably not as mobile. And so people that are, out catching the COVID or bringing it home, et cetera, et cetera. And when they do that, it starts to tick up in our wastewater. So you start to see the wastewater surveillance is going up. So that's one signal that is concerning. Another signal is the R effective rate. So again, this is just a theoretical measure of how contagious the disease is. But anytime a disease has an R effective greater than 1, which is the dashed line here, then you know that one person is spreading it to more than one person. So an R effective of 1 means one person spreads it to one other person, and that disease stays kind of static in terms of the numbers. Whenever the R effective is greater than 1, it means that it's actually transmitting, and sometimes it can be up to like 13 or 14, which means that it's basically spreading astronomically. Here it's 1.13, so it's slightly higher. But this could be the start of increased spread as a result of holiday gatherings. The case rates, again, the wastewater goes first, then the R effective. then the case rates, then the hospitalizations, then the deaths. That's how every surge with COVID has been. And so right now we're seeing signals in the wastewater and signals with the R effective rate, but it really doesn't show up to be looking that impressive whenever you look at case rate per 100,000, which is why that first table that I showed you with all the nice colors basically was pretty static, maybe just a little signal going up. But here's what the smart people at the state are saying is going to happen. So December is going to give us lots more COVID cases. They're saying a modest increase, but you can interpret that the way that you want. And I would argue that even a modest increase is going to be very burdensome given how strained our hospitals already are. But nonetheless, the modeling suggests that COVID hospitalizations will increase. And so, we all need to know that we're getting ready for what could be the start of the winter COVID surge, which usually happens around Thanksgiving, because people like to gather, kids are home from school, then they come back and give it to each other right before the winter holidays. Then people gather again for the winter holidays. And then it basically is just a vicious cycle that we get caught in for several months. And so that's, I want to brace everybody for what we're seeing as like, this might be the start of it. What we're hoping is that this slide really reveals the strategy that we're using to pull people through, which is vaccination. So here's all the people that have gotten vaccinated. And this is a chart that has started ever since late 2021, when we first started doing vaccination. Well, late 2020, but anyway, when we first started doing vaccinations, there was just a trickle of supply and then it really blossomed. And so ever since then, we've been counting how many people have gotten vaccinated. And, approximately 2/3 of our county have been quote unquote fully vaccinated, which is a good sign. However, there's some age groups that are really lagging behind. And there's actually pockets of people that need to get their booster shots, which is my main concern today. So this is the booster vaccine data. And here, the best thing you can do today for COVID is to go get a bivalent booster. If it's been more than 2 months since your primary series, if you're, even if you're a kid, you can qualify for a bivalent booster at this point. You really should be getting a bivalent booster. Not enough people are doing that. Only 8.5% of Fresno County has a bivalent booster. This boggles my mind. I was wondering if this data is accurate, but I'm afraid it is. And so we just need to be doing better about telling patients that, look, I'm glad that you survived COVID, or I'm glad that you got your vaccine way back, in 2021. It's now time to get this bivalent booster. It's not good enough to say, I survived COVID, I'm going to be fine, or I had my vaccine very early on in the pandemic. Guess what? The bivalent booster is the current way to level up your immunity, and it's the safe way to level up your immunity, because unfortunately these Omicron strains keep mutating, they keep spreading, they keep kind of selecting amongst each other for, basically that's what viruses do. They compete for, the ecological niche, as it were, for where they can survive and spread best. And the best thing we can do is really nip all that in the bud by not allowing them to have more victims where they can mutate. And that means getting your boosters. In terms of kids, again, kids 0 to 4, again, these vaccines came online later. I can understand there's some hesitation and extra questions that parents might have about their children. Nonetheless, the safety is there, the efficacy is there, and a lot of pediatricians have stepped into this, but we need more to do that. And to really come up with better partnerships with our schools, frankly, to say, what can we do to get kids vaccinated? Because we're looking at 3% to 30% in the 0 to 11 age group. And that's kind of scary, that those kids can still get COVID. They can bring home COVID to their elderly relatives. They'll miss school. They'll be disrupted from their sports activities, et cetera. All of that could be prevented from these vaccines, which should really just be seen as routine childhood vaccinations at this point, alongside everything else that we're vaccinating kids for with very good reason. Okay. Again, I don't want to belabor the story of how much work we need to do for vaccinations, but as we talk about even more gloomy topics later on this hour, the question is going to come up in your mind, like, what can we be doing, to help the hospitals? What can we be doing to help with this triple demic? Well, guess what? This is what we could be doing. We could be really getting people to get their COVID shots, because that's one more disease that we take off the table. We've got enough on our hands with the flu and RSV, which I'll talk about in a minute, but we could really just put COVID way behind us, or really knock it way down, if we just got more people getting their bivalent boosters. So that's why I keep reiterating, all ages need to get this. And this, I don't want this to get lost in the headlines of, RSV obviously is very appropriate to focus on that, but I don't want to get lost in the shuffle by forgetting about the fact that we still have gaps to fill with COVID vaccinations. So in terms of what works, I think that, to their credit, the state has basically been studying communication strategies, and they've really come up with some good lessons that I think everyone needs to know about talking about these diseases. Because again, everyone's kind of heard the same messaging ad nauseum, and the people that are going to respond have already responded, and the people that are going to tune this out are basically lost to all this messaging. So the state is really trying to say, look, we need to do a reboot and say, these are the lessons that we're going to start with to really respond to this winter season that we know is going to be very challenging. Awareness of treatments is minimal. So people know about COVID, the disease. They're pretty good at getting the test. They kind of understand that you need to stay home if you're sick. All of those messages have kind of hit home, but people still don't understand that there's good treatments for COVID that can keep people out of the hospital, get them better, maybe even prevent long COVID. All of that awareness is really minimal. And I think it really starts with us as physicians to say, we're going to lead the charge on this messaging. Even though we may not know all of the different prescriptive details and maybe even the side effects, we're going to lead the charge just to let people know that COVID is a treatable disease, and it's treatable with medications that can be prescribed. And really, I'm going to share some really cool telehealth solutions that will make your life tremendously easier. You definitely don't need to be an ID expert to start doing this. You can basically just tell people, you know what, there's a treatment available. I'm going to hook you up with someone that knows what they're doing about this, and really pass that patient off within the first 5 days of their illness to someone who could prescribe a treatment with telehealth. Okay. Use affirmative messaging. People don't want to hear, well, you're going to die, or you're going to be a terrible person, and blah, blah, blah. People want to hear affirmative messages. Give people a reason to live. Lead with positivity, optimism. They tune out warnings related to hospitalizations or death, but they really seem to respond whenever you message in a positive way to say, here's all the benefits of doing this, whether it's testing or treatment or vaccinations. Really focus on the benefits, not on the negatives. I think that's human nature, especially coming out of this pandemic. People really want to, think about something positive instead of going back to the gloomy times of the darkest days of the pandemic. Don't focus on eligibility criteria. Really, people are like, well, if you meet this checklist, then you can go get a vaccine. You should really just say, look, everyone deserves to get a vaccine. Go check out if you deserve it or not. Go get registered. And most adults are now meeting the criteria. This also goes for monkeypox, which we really struggle with getting people vaccinated. And I think we're getting hung up on eligibility criteria. Eligibility criteria are designed to ration limited resources. That's it. That's really what they're designed to do. When you don't have limited resources, we now have great supplies of vaccines for just about everything, whether it's COVID, influenza, monkeypox. We have good supply now. So the eligibility criteria is less important than just pushing people to go get their vaccine so that we can get them protected and really protect the rest of the healthcare system as well. So we need to avoid focusing so much on the eligibility criteria right now. All right. Just basically shifting your attitude from resignation to motivation. I really love the fact that this slide is from the State Department of Public Health. It was developed by professional communicators. They don't understand that all caps is a total party foul. But anyway, there you go. All right. Great messaging coming from the CDC about Thanksgiving and the FDA. Again, this very positive time that the holidays represents, you can really leverage that momentum. People want to be with their families. They want to keep their families safe. you can leverage that feeling that everyone has to say, look, we know you want to prepare for the holidays and do it right. Part of doing it right is getting your vaccine. So just do that. And if you happen to get sick, sit out until you get better and get tested and get treated, because you can beat it that much faster and get back to living your life. If you start to feel sick, act quickly. So here's some talking points. I really want you to just commit these to memory as I talk about them, because they're not hard at all. And they're really going to help, again, overall. And I'm not thinking about this week or even next week. I'm thinking about the really dark days of winter when everything's hitting the fan. We really need to have these messages just committed to memory so that we can just, they roll off our tongues when we talk to our patients and when we talk to our staff, because staffing shortages, again, they're going to come to bite you if you're not careful. Again, we want to be cognizant of these medications that can really help with COVID. COVID treatments have to be taken within 5 to 7 days. The majority of adults are eligible, and treatments are safe, free, and highly effective. They can actually reduce the risk of severe illness, hospitalization, and death up to 88%. And that's a New England Journal randomized controlled trial. No one's questioning that science. That's really how good these medications are. And it's kind of tragic that, we suffered so much and sacrificed so much during this pandemic. And now that we have these amazing medications, ironically, they're being underutilized. So that's why we need to commit all of these talking points to our memories and really talk to our, everyone in our lives who has COVID. We can really get them to test negative sooner, keep them out of the hospital, keep them alive if they just get on these medications. And the latest research is that this whole thing of long COVID, which can be a very debilitating disease cluster that can last for many months, and no one knows if it's going to last for years or become permanent. But the preliminary research shows that these medications actually show a benefit for that too. Again, you don't have to necessarily memorize all of these details, just know where to get this information. So I included a hyperlink for this really nice flyer. You can have this out in your lobby. You can share this around on email with all of your staff. Really just get this good information out there so people know what to do and when to act whenever they get COVID, so that they can get access to these treatments. Here's the long COVID paper. I'm not going to belabor the statistics. Again, it's not quite ready for prime time because it's published in a pre-print journal. However, it's very promising. Absolute risk reduction, anytime that's over 1, you're looking at good numbers. So post-acute sequelae or long COVID, here the Paxlovid really had an absolute risk reduction. Post-acute hospitalization and post-acute death or hospitalization all showed a benefit. Really, people are excited about this paper. Telehealth. So this is something you may not be aware of, but it's never been easier to get medications for COVID if you test positive. Obviously, you can't test people over the telephone, but as soon as they test positive, they should be on the phone with a provider who can get them a medication. Then they can just go to the pharmacy and pick it up. And if you really make that seamless, where you just say, I'm going to swab you today, but I need you to have this phone number handy and call this as soon as you find out that your COVID is positive. That's really all you have to say. And then they take care of the rest. And they have a beautiful website. They speak a bunch of different languages. You can get an availability, within the next 2 hours. And really, it's really well done, and it's all totally free. And they will send in a prescription to the pharmacy that the patient chooses. It's a really well done process that's being way underutilized for COVID. So just think about this, because I think this is really going to be a very key layer of the strategy for this winter COVID response. Remember when we had to set up monoclonal antibodies for people, and really we were scratching our head about how to make that happen, and really set aside clinic space in our clinics to make this happen. This is all telemedicine with outpatient medications. And it's coming soon via DoorDash to people's door. So even DoorDash is getting in this, and DoorDash will literally deliver these free medications to people's houses. That's not ready for prime time in California, but it's already being premiered like in other parts of the country. So that's something else that's coming down the line. Again, this is just some data that the state shared. There's only been about 600 appointments, from July to the end of October. That's not a lot of appointments when you think about how much COVID there is out there, and it's just going to go way up. So we need to get in on this and let our patients know that this is happening so that they can start to use it, especially before. Hopefully it won't get overwhelmed, but that's what I'm afraid of. So we just need to show that Fresno County can do this and that we need to do this. You know, we're always complaining about our rural populations, how much access to care difficulty there is, et cetera, et cetera. Well, this is a telehealth solution that actually addresses all of that. And this just shows you where all of these appointments are happening, mostly in Southern California, but we can certainly do more of this in Fresno. And I think a lot of your patients would appreciate having a telehealth connection to basically just get their meds called into their local pharmacy. Then they don't need to go to urgent care or primary care or the emergency department to get medicated for COVID. Okay. So just to wrap up the COVID discussion so I can move on, it's going to get worse. I wish I had better news, but it's going to get worse in the weeks ahead. The signs are pointing to, you know, basically right after Thanksgiving and hurtling towards Christmas, you're going to hear a lot more about COVID, you know, intensifying and causing some real strain on our hospitals. So right now is the time to really intensify those messages, to lead by example, to make sure that you're masking, especially when you're out among strangers, and then doing your universal masking policies in your clinical areas, making sure that you have good policies for people to stay home if they're sick and to isolate so that they're not spreading in the workplaces where you're working if they come in symptomatic and they're not masking. We know masking works. We know isolation works. We just need to get, you know, not forget about all these hard lessons that we learned the first few times around and really bring that back. And of course, we need to get people vaccinated, especially with the bivalent booster. And that means for all ages. Sorry, I forgot that sentence. Test to treat options are underutilized. Use telehealth. And then if you have resource requests, remember, we have the Mohawk system and we can help with supplies, PPE, medications, testing supplies, whatever you need, let us know. And we will try to either find something in our warehouse that fits your needs or elevate that request to the state. It works really well if you communicate early and often. So do your inventory starting now, even if you're not feeling any pain related to all these headlines. Start doing your inventory and think about the dark days ahead related to COVID, which probably will affect your practice, and just be prepared because there's no reason to really suffer this winter. We have so many great strategies, and we really think that we're going to have hopefully an easier time than we did last winter, but it's still going to strain us. But the more that we can do now to prepare and protect, the better off we'll be. And I'm really excited about this DoorDash partnership because you know, it's the right thing to do. It's really going to help a lot of underserved populations, people that have transportation issues, et cetera. And it's going to keep the rest of us a little bit safer too. All right, let's talk about these new diseases that you've probably seen hit the headlines. There's flu and there's RSV. They really kind of go hand in hand in many ways, but I tried to break it up so that you could see each one as its own kind of epidemic. But just realize that when patients feel like crap, they feel like crap. They don't know what they have. They're just going to come in looking for help, and basically it's going to be hard to tease out exactly what people have. And that's why the triple-demic is really going to affect the healthcare system, because people, regardless of what they have, are going to just come access whatever healthcare door they're familiar with or that they can get access to. And that's really going to strain the system. It's already straining the system. So make a strong influenza vaccine recommendation. That's my key takeaway for flu. Flu, remember, the vaccine is approved for anyone ages 6 months and over. It's actually required for healthcare professionals, but even for non-healthcare professionals, we can really do a lot if we get people vaccinated against influenza. Unfortunately, with the masking being what it is, we're not going to be able to have the great year that we had last year and the year before. Influenza is already showing signals ticking up. So I added some stuff right off the bat about how you can be very confident about making that recommendation for an influenza vaccine. It really does help. Even if the patient says no today, you've planted a seed in their mind, and that seed is going to germinate. And they're going to come back, or they're going to follow up with someone else, and they're going to go get that shot because they heard you say that you recommend it, and that you're worried for their health if they don't get vaccinated, and that you see a lot of benefits if they do get vaccinated. and just keep reminding them over and over again about how serious influenza can be and how preventable it is with these vaccines. The vaccines are actually pretty good this year. They seem to be covering the strains that are dominating. So that's another plus with these vaccines this year is, sometimes they're not as good, but this year they seem to be covering the strains that are dominating. All right, so this is the first of the oh dang slides, okay? Influenza season is starting early. So all of these different colored curves are basically what happens with influenza detection, which is real diagnosis, not just symptoms, at some of the sentinel laboratories that are set up really all over. And really there's a peak that usually starts in December, peaking in the early months of the year, and then coming down in the spring. Guess what? This peak is starting super early. It started like almost in October, and now it's going up. And this is just taking off in such a way, even though there's only 3 or 4 data points here, it's taking off in such a way that people are quite worried that, we had 2 very light years with influenza. That's because people were masked up. People were really cognizant about the risk, and they decided to get their vaccine. None of that is, it seems to be in play this year from what the best evidence suggests is that people are not masking as much, and people are not getting the vaccine as much this year for the flu. And really, we've got to change that narrative, because the way things are going, this is going to be a really hard flu year. So that's why I just said, oh, dang. Okay. In terms of total flu hospitalizations, those are already going up for how early this is in the year. It's low compared to historical flu seasons, but it's a very early start. So again, there's some worrisome trends about influenza. Bottom line, masking and vaccinations are the best strategies that we have. There's also the antivirals, but that's such a reactive strategy, and you're basically throwing into play all of the challenges that people have. Transportation, getting to see a doctor, getting a prescription, having access to a pharmacy. The pharmacy has to stock the drug. So it's not by any means a perfect response, even if we do have the flu antivirals. It adds so much a logistical burden that it's really not seen as a strong way to respond to influenza. The best thing we can do with influenza is just prevent it and prevent spread. If people are symptomatic, have them stay home and get tested, and then just stay home until they're better. RSV. Okay, so this is very interesting. Again, not being a pediatrician or peds ID person, this is not exactly my area of expertise, but there's some very interesting epidemiology that's being done. And what RSV seems to do is, it has a peak and then it kind of ebbs, and it may even be bimodal, but nonetheless, it usually peaks, in the early winter and then basically goes down. And it seems like with COVID, because of the masking and the social distancing, the isolation, a lot of babies did not get their normal RSV virus. So now this is kind of like seen as a makeup season, for lack of a better term, to where there's going to be a lot of vulnerable populations and more kids have been born. And now all of that is kind of creating a perfect storm where there's just a lot of kids that don't have RSV antibodies, a lot of older kids, and now they're all getting RSV. And it can actually spread to adults too. So I'm going to share some slides about what RSV can do. So this should be called RSV 56, but it's just called RSV. It was discovered in 1956. As you've probably heard, it can cause a lot of different respiratory illnesses, ranging from just a cold and sniffles to bronchiolitis and pneumonia. 1 to 2% of kids younger than age 6 months will get hospitalized. And even though young infants are classically affected, again, like I said, older children are now being seen as part of this RSV surge. And really the high risk conditions are the folks that we really worry about. Premature infants, those under 6 months, younger than 2 years with chronic lung issues or congenital heart disease, immunosuppression, neuromuscular disorders, difficulty swallowing, difficulty coughing or clearing mucus secretions, those with decreased appetite and dehydration. And in fact, rhinorrhea and decreased appetite are typically the initial symptoms, and cough usually develops 1 to 3 days later. I'm saying all this because I think we should have a general just knowledge of what this is, even if we're not pediatricians, even if we're not working on the front lines, because this is so common. Whenever we do our health advisory, we're going to have a section that says what every clinician needs to know about RSV, because I feel like whatever you can do to advise people and triage them before they have to go sit and wait 8 hours in an emergency department to be told that their child is going to be fine and that they just need to go home and have supportive care done. If you can at all triage people so that only the people that really need to be in the emergency department are there, that really helps. And I think it's up to all of us to help with that triage process, because the system is really straining. And the more all of us know about what this is, I think the more confident we'll feel in the advice that we're giving. And then hopefully we won't have that panic reaction where we just say, oh, you know what? I don't know anything about this. Go to the ER just in case. Okay. That's actually going to be counterproductive as we try to respond to this surge that's affecting very young kids, but it can also affect adults too. Okay. Lots of links that I've included here that you can read about this if you're curious. And many webinars and videos are being produced right now to help really do just-in-time training for the medical community and for parents as well. RSV does affect adults. It's usually an upper respiratory or flu-like illness. We worry about older adults, people with lung disease, people with heart disease, and immunocompromise. And really, there's thousands and thousands of adults that are getting hospitalized by RSV every winter. And so it's not something that makes all the headlines, but just keep in mind that you really should be testing, especially if they're flu negative and COVID negative, for a viral respiratory panel, including RSV. Treatment pretty much is supportive, which is not to say that it's easy, because even supportive care can take a lot of resources. You can run out of ways to give oxygen for those who need it, ways to provide bronchodilators. The best evidence that I've read, and again, for those of you who know more than me, please speak up. Steroids don't help. Antibiotics, because it's a virus, don't make sense to give. And really, you're going to be just trying to determine is this patient getting too tired to go home? In which case, I need to keep them in the hospital, start supplemental oxygen, and then start supplemental breathing for them, either with non-invasive or invasive ventilation. And that's really the bottom line. And then that too tired to go home, as you can imagine, that's a clinical decision that has to be made that requires a lot of vigilance. And that's really where I think the strain in the healthcare system comes in, is that that's really hard to automate, and that's really hard to do remotely. And that's why people need to be seen by a clinician. However, if they could just get supportive care, maybe they wouldn't get that bad. And so that's why we're trying to get everyone to know about this and not spread it, et cetera. There is an antibody prophylaxis that's called Synagis or palivizumab. The pediatricians know about this. There's great literature from the American Academy of Pediatrics. It's really reserved and frankly, maybe hard to obtain even for patients that qualify, which again, sets us up for, the surge that we're experiencing. But really the criteria, and some of these criteria are softer than others, but really infants that are born premature, those that have chronic lung disease, these are usually all babies under 1 year of age. There's very few indications for babies over 1 year of age, but nonetheless, there's some indications for babies under 1 year of age. Prematurity, chronic lung disease of pure prematurity, or significant heart disease or other immunocompromising condition. Those may qualify for this rather expensive but life-saving monoclonal antibody, and that might help them if they do get RSV to fight it a little bit more strongly. This is an intramuscular injection. It can be given once a month for up to 5 times from what I've read, and I'm sure there's a lot of flexibility in gray areas there, but that's basically the rhythm of what you're supposed to do, is identify a high-risk patient, bring them in, get them this shot, and then bring them back every month or so and basically keep them going until they're strong enough or that they graduate out of these conditions, or until the RSV season is over, which, it shouldn't take longer than 5 months, but sometimes it does. But really, tragically, a lot of patients that qualify may not know about this or may not have access. And so that's the reason why I'm bringing it up, is please advocate for your patients. Or if you're in a position to provide it, please provide this for patients who qualify. because this is just one more layer that we can add to this response to keep kids out of the ER and out of the hospital who qualify for this antibody. And you can read lots more about it at these links that I've provided. Okay. All right, so why are we even talking about all this? Well, just focus on the colored lines here. You know, the black line, the dark blue line, and the red line. All of these are going up and up and up, you know, from late September all the way to now. And this is local data on ED visits that Dr. Kokumar generated for us. And this is basically just showing that we are indeed straining with the number of kids that are being seen for what's known as flu-like illness, but it's basically RSV in this age group. And I'll show you some data for that. Kaiser Permanente actually keeps really good records, and the Northern California Kaiser group is showing that, you know, in this slide, it's really that young age group that's driving their visits. And again, these are visits for influenza-like illness, by which, you know, that could be any kind of virus that's causing this, including COVID, RSV, influenza, or none of the above. But for the most part, this is being driven by RSV right now. And it's really that 0 to 4 age group that's just spiking, followed very closely by the 5 to 24 age group. And again, probably the 5 to 10 age group that's just spiking. Okay. Regional RSV trends are showing increases statewide. So these are specimen positivity. This is no longer talking about symptoms. This is talking about specimens that test positive for RSV. It should be around 10% or less. Now it's up to 30%, and that's being seen statewide. And so again, more intense positivity means that the RSV is definitely out there and circulating and causing problems. And here's what the actual diagnostic specimens for RSV are showing, is that, again, it's similar to the flu charts that I showed you, where these different colors of the solid lines are from years in the past. And here you see that these orange solid lines, which is this year's RSV season, is like way higher. You know, it's way higher. It's starting too early. It's actually peaking above the peaks that we had in the last couple of years. And so that's why it's really scaring people, is that we're looking at like a King Kong curve, as it were, of RSV this year. And that's in pediatric patients. The non-pediatric patients as well are getting hit. And so again, this is speaking to the fact that adults can get RSV, and then they're actually coming in at higher rates as well. Okay, so this one slide explains all the headlines that you've been reading about RSV, is that this is why people are really worried, because this is just intense, and it's quite impressive what this thing might look like before it's all said and done. There's really good information out there, fact sheets you can print out and just have in your lobby. Maybe even consider, if you have an email listserv, send this out to your staff, send this out to your patients, especially your high-risk patients or parents of young children, and just say, I need you to know about this because I think that you're at risk, or that you just need to know this is really good information from the CDC. Let's make it widely available. And then really just, you know, next time you have a staff meeting, talk about this so that everyone's on the same page about how they can stay protected and who the high-risk patients are. Key points. They're both RSV and flu are having very early starts to their seasons. So even though, like I said, the COVID numbers are looking kind of rosy, depending on how you slice and dice it, these numbers are not looking rosy. This is already happening. And that's why the hospitals are telling us they're very severely burdened by the number of people coming in with flu-like illness that ends up being flu or RSV or some other virus that's causing similar syndromes. Pediatric hospitalization impact is attributable to several factors. And again, not just in Southern California, but everywhere. The models and the data suggest that there is an increase. We know that California is lagging behind the East Coast, and the East Coast is really going up. Importantly, COVID is also increasing, and the focus is on pediatrics now, but older adults can and will have a tough winter because of this triple-demic. That's my forecast, and I think we need to brace ourselves for it. Any questions about all the stuff that I've talked about? These are a bunch of links that I just threw in there as I was doing my reading, but they're really good. I would say the top two are essential reading. So this is your homework for this weekend, is read the health advisory put out by the state health department about the early respiratory RSV and seasonal influenza activity. And then also there's a pediatric respiratory virus AFL, or all facilities letter, that's also worth your time. And so you should be familiar with that, because that gives you really good updates on what the state is doing to respond to this surge. There's lots of other learning opportunities from the CDC and the CDPH about flu, RSV. We didn't even get to Ebola today, or non-tuberculosis mycobacterium. I just got an email from LA that they're dealing with typhus. So there's lots of other stuff that I'm not even going to talk about this time around. We need to talk about perinatal substance use disorder, and go back and update you on monkeypox. We will get to that. I just wanted to leave room today for the respiratory stuff and make that the theme of today. But next time we meet, we will talk about a bunch of other diseases that I didn't get to today that are, if not on the back burner, then perhaps less priority than the pediatric respiratory issues that we're dealing with now. But these should be on your radar as well. So maybe you can scroll through and look at all these links and just be aware that this is happening in case one of these comes to the fore because an issue has entered our county. In terms of the regional surge advisory, we're basically going to break it up and hopefully release it in the next few days. We're working on it now. It's going to look like advisories that we've produced in the past, but obviously they're going to have current updates, current statistics, and have a new focus on influenza and RSV, which the updates in the past didn't really need to. We'll talk about the current situation in Central California, which you just heard for the last 30 minutes. How can all medical providers in the county help at this time? Hang on just a minute, I have to. Sorry, hang on just a minute. Actually, you can read through this. Sorry for that. Okay, so like I said, this is the surge advisory that our team is putting together. Dr. Solis, Dr. Zweifler, myself, and the leaders at the health department. How can all medical providers in the county help? What are the updates related to vaccinations and therapeutics? And then, just what every clinician needs to know about RSV and the bronchiolitis syndrome that it can cause. So that's going to be kind of the nuts and bolts of this regional advisory, and look for that to hit your inbox as soon as we've prepared it. Like I said, we want it to be regional because we feel like we do need to act as a region in Central California, and we're trying to recruit some of our other counties to help us with this messaging and help coordinate as needed with the needs of the healthcare systems in all of our counties. So that's kind of the, hopefully this will be a description of what that plan looks like. And this is just a picture from my emergency department at CRMC. This is a key tool in our toolbox for RSV, which is a nasal cannula called an Optiflow Junior. And this delivers very high levels of oxygen. It can actually humidify the oxygen. And this is the one tool that many kids need. And that's why they're in the ER. They belong in the ER, is because they're not going to get better or thrive without getting supplemental oxygen with the Optiflow Junior. And so it's really neat technology. It actually heats the air and the oxygen and mixes them together as it delivers into the nose. And it's something that's helping a lot of kids all around the country, but obviously not something that parents have at home. And so a lot of these kids, if they're not getting better on their own, do need to be in the emergency department. We just have to really work hard to make sure that kids who can otherwise be home can stay home, so that we're not taking up beds and taking up resources for kids that actually need to be there. And I know that that's a very hard task. All right, so let me end with some good news about substance use disorder. So there's actually new hope for methamphetamine addiction. There was a nice story about how methamphetamine addiction might finally have an effective treatment known as contingency management. This is actually not pharmaceutical based, it's more behavior based, where people get material rewards and really just other very positive reinforcement related to sobriety around methamphetamine. And really the evidence speaks for itself. As you know, a lot of people are trying a lot of different things, but amphetamine addiction really seems to respond to this contingency management program. And it's now really getting the scale up that it needs. And a lot of counties are getting grant support to do it, including Fresno County. So you're going to be hearing more about that. And, you know, with the methamphetamine problem being as large as it is in Central California, everyone's desperate for a cure. And this might actually be a way of helping at least some of those patients. So it's something that's kind of good to read about and just be aware of. I had a great time. You can see this picture. My team and I from the hospital went to the medical school at the California Health Sciences University, and we trained all of their medical students on how to give Narcan. So this is something else that you've heard me talk about before. All of you can actually do this. It's not hard at all. We really need everyone, whether they're clinical, non-clinical staff working in healthcare, and just members of the general public, to know about Narcan, know how to use it. So this was a really fun activity that just showed it can be done. We can do mass classes like this and really just do citywide trainings if we need to, where we bring a lot of people together. And now all of these medical students are now trained to help us turn around and train others. So that was a really nice activity that you can read about. Addiction medicine is now getting more and more attention as something that needs to be a service line in a lot of different hospitals. So I'm really glad that NPR did this story. This is something that is really direly needed in so many different facilities. And really this just talks about some of the challenges, but also the solutions of getting addiction medicine service lines started at various different hospitals and facilities. So I just wanted to share that as another update for you to look at. And finally, if you're a prescriber, you need to be an X-waivered prescriber. It's that simple. This is really one of the main ways that we can put a real dent in the opioid epidemic, is aside from Narcan, which anyone can give, really any prescriber can give the life-saving medications that can keep people in recovery if they have their X-waiver. I've X-waivered people in 3 minutes. I mean, I actually counted. It takes 3 minutes on this government website. You can start at this link. So I know it can be done. I need you to push yourself and push your clinicians to get your X-waiver. Make that a New Year's resolution to say, let's get this opioid epidemic actually controlled with the X-waiver so that we can start prescribing the medications that we know keep people off the streets doing drugs and into recovery where they can stay safe. And really they can start to repair their lives. So look for that in that final link at the very bottom. And I think that's it. Just a reminder that we have our Fresno Madera Medical Society Awards Gala. So that's coming up on Friday evening. I hope to see some of you there. My wife and I are looking forward to going and reconnecting with many of you and really helping to celebrate the installation of new officers, as well as the awards that are going to some well-deserving physicians in our community. And we really hope that you'll be able to make it. If you're still interested, you can RSVP to the Eventbrite site that's at the very top. I love it when people call it the RSVP virus because it's just really cute, but it's actually not. It's the RSV virus. All right, let me go through and see if there's any questions in the chat, but please feel free to unmute yourselves and let me know if you have any questions. The question somebody brought up is the Sesame telehealth available to COVID positive via self-referral? And the answer is yes, absolutely. That Sesame Health website is just a one-stop shop. If you know you're COVID positive, you can basically call that number and they will set you up and you don't need to get a referral to do it. And Sim, thank you very much for adding this letter from Dr. Aragon, our state public health officer, about the ways that the state is collaborating with different agencies. So the Bridge program, which I've been a part of for several years, is now collaborating very deeply with the CDPH Office of AIDS. And they're really just saying more hospitals need to be doing this Behavioral Health Navigator program, which we've already done. We've gotten this award, but if your hospital has not gone down the road to apply, you have until December 15th to do the application. It's super easy to do the application. Please contact me if you're getting hung up on it. because I've already done it. We got the award for CRMC, we got the award for Clovis, and I know several other hospitals in our area are already either working on getting their application done or have already gotten approved for this award program. Any hospital with an emergency department can get this program, and it's basically free money so that you can hire a substance use expert that can work with your patients and really get the training that they need to be successful. It's a really great program, and I can talk more offline if you have any questions about it. Any other questions? All right, so someone's asking, any upcoming training for Narcan certification? Well, that's a great question, Dr. Mitchell. My team at CRMC can actually come out and do a quick training with your group. You can, if you could set aside half an hour to an hour, we can come kind of do our presentation. We teach all about the opioid epidemic, drug overdose, signs and symptoms. Then we actually have really cool models like Narcan trainers that we come out with and show people how to actually do the intranasal delivery of the Narcan. It really lets people have a hands-on experience and be very confident that they know what they're doing. And then they're ready to go. And really all of your staff should be trained on this. And not only should they be trained to do it themselves, but they really should be training other people. So we really support a train the trainer model where we want your staff to be Narcan educators and we want you to be a Narcan distribution site. That's the ideal. We just need more sites in the county for people to walk in and go pick up Narcan. And we would love for Fresno State Student Clinic to be one of those sites. So definitely would love to talk to you offline about how to make that happen. Great. Well, I know that that's a lot to think about and look at and read about. Like I said, look for our surge advisory, but even before, look for these notes. I'll send them to Sim, and Sim will send them to your inbox so that you can have all of these links to start going through. And hopefully, if you have any more questions, please reach out to us. Otherwise, we will definitely schedule a time to talk again and stay caught up on the triple-demic, but also talk about some of these other diseases that we didn't get to today. Thank you all very much. Really appreciate your time today.
Thank you, Dr. Vohra.
Have a great Thanksgiving.
Thank you.
You too.
Take care.